So that's the FFP3.
One of them, yeah.
And that's the fluid-resistant surgical mask. As a layperson, just putting that on, there seems to be lots of gaps, it's quite flimsy, but putting that on, I had to be shown how to do it, going back to the fit testing. Surely that just looking at it, that offers so much more protection. It must do, mustn't it?
But can I just explain one of the challenges that we have is that the in hospitals there was, and I have no doubt there was transmission from patients who had infection. But I think, as you've seen in some of the studies, that the most transmission was from healthcare worker to healthcare worker, which would mean they needed to wear those all the time. And then there was significant transmission.
That's a different point. I'm sorry, Professor, I'm going to have to interrupt. That's a completely different point. It may be associated. There may be disadvantages to wearing them all the time, and you may get the ulcers. Some may say getting an ulcer isn't as bad as getting COVID, but there are all sorts of arguments. I just want to challenge that article, basically, there's weak evidence to say that the apparently much stronger looking, closer fitting, has to be fit tested article, there's weak evidence it offers better protection than that.
Correct.
Well, you're sticking to that.
I'm a clinician and scientist, and I can only go with what the evidence has done from looking at it in hospitals, in healthcare facilities. And I think that, that when we do something, when we talk about wearing something rather than just wearing it for 5 minutes or 10 minutes and looking at it in that way, we have to talk about how it's worn for a 12-hour shift, how it's worn repeatedly day after day. And that's about operational interventions that are able to be applied for many days, weeks and months. And that's where they work really well in the lab. Don't get me wrong, the laboratory is really clear. But when you look at them in practice,
it's the way people wear them. In other words, because they're uncomfortable, they might take them off.
Well, they may be all of those things, but that's what matters when you try and do something in practice, is does what happens in the laboratory actually work in practice in real life?
Do you agree that where there is an accepted risk of aerosol transmission, FFP3 masks should be recommended?
So I think this is, again, quite a complex area. And I think that, if I may, I would say that when we look at the components of fluid-resistant surgical masks versus FFP3 masks, we look at the evidence that we have available and their effectiveness of use, both the laboratory evidence, which is one element, but then the evidence in clinical practice. And where we looked at it and repeatedly looked at it and are still looking at it, the evidence is weak that they actually, FFP3s, protected more than fluid-resistant surgical masks.
Come back to what you said. I had understood the position that respirators offer a higher degree of protection to those wearing them than those wearing an FRSM mask. Do you agree or disagree with that?
So they offer a higher degree of protection that's been studied in laboratory procedures. When we look at it in clinical trials of various different types, it is very mixed, actually, and in some studies there's no difference between them.
If that were the case, why bother pushing them on then for AGPs at all?
So again, AGPs are pushing out what was thought and what is considered to be thinking is that AGPs are pushing out a large volume of aerosols, and you're in very close proximity to the individual, and that higher level of protection therefore may help. When we're looking at wider airborne, what we're trying to do is a variety of different components of control, and we are looking at all of the different elements of practice to try and reduce any elements of respiratory transmission. I would say that if we were to look at the evidence and use and require FFP3s, then given people are coming to hospital with respiratory viral infections all the time, then we would be asking people to wear them all the time, but we don't. We ask people to wear them at very specific moments, using all of the other elements as a priority.
Professor, can I just ask you this? I understand that you're drawing a distinction between the level of protection that is deemed as a result of a lab-based experiment, and you said it was different in a clinical context, but if in reality in a clinical context it makes no difference, why on earth is there all this controversy about whether you should wear an FRSM and an FFP3 if in reality it makes no difference?
So, I think that we can ask lots of people that question. I think that there's benefits that are seen where you can eliminate the risk of an infection. However, when you're in the middle of a pandemic, you can't eliminate the risk of infection. What we know is that healthcare workers and the community were suffering infection rates at the same, roughly the same rate in the population, because the infection was transmitting and around us in all places. Therefore, what you're trying to do in healthcare is to really, where the risk is